This video is going to be all about the tensor fascia lata muscle, or the TFL. We're going to begin by reviewing some of the relevant clinical anatomy, and then we're going to move into 3 good stretches for this muscle. Now, the TFL, or tensor fascia lata, is shown over here in green. You can see that it's part of the lateral hip musculature, the other lateral hip muscles being the gluteus medius and the gluteus minimus. And the tensor fascia lata lies anterior to both of those muscles, both of which happen to be more posterior. Now, the tensor fascia lata muscle originates partially off of the anterior iliac crest, specifically the outer lip, but mostly off of the anterior superior iliac spine, or the ASIS. That's where the majority of the origin fibers come off of. Now, this thickened part right here in green that I'm circling, this is the muscle belly of the tensor fascia lata muscle. But notice as you get down more to the level of the shaft of the femur, it narrows down into a very large thick tendon, which is the iliotibial band, or the IT band. And from my mouse right here all the way down to the distal attachment, or the insertion down here on the tibia, this is the iliotibial band. That being said, the insertion of the TFL depends on what source you're looking at. Because the IT band itself is such an important structure, some sources will actually say that the TFL inserts on the IT band. So the insertion would be listed up here where my mouse is. But other sources will take this further and consider the TFL and IT band to be one continuous structure. And so they'll say that the insertion is more down here, down by the distal attachment of the IT band. And so you can see here that off of the anterolateral tibia, there's a small protrusion called Gerdy's tubercle, and that's actually the distal attachment of the IT band. So you might see the insertion of TFL as being either the IT band itself or Gerdy's tubercle on the anterolateral tibia. The TFL has several actions at the hip and the knee. At the hip joint, the TFL facilitates internal rotation, but to a greater degree than it does abduction at the hip. Remember that the major hip abductors are gluteus medius and minimus. Even though the TFL participates, it's a much stronger internal rotator of the hip. At the knee joint, the TFL can facilitate external rotation of the tibia relative to the femur, that would be in open chain positions, but also flexion of the knee or extension of the knee depending on the hip position. So if the hip is more flexed, then the TFL will facilitate more knee flexion. If the hip is more extended or closer to neutral, the TFL will facilitate knee extension. And overall, this muscle facilitates hip and knee stabilization, considering the fact that it crosses both joints. The TFL is innervated by the superior gluteal nerve, the same nerve that innervates both the gluteus medius and minimus. And it also has the same nerve root contributions, L4, L5, and S1. Blood supply to the TFL is via the ascending branch of the lateral circumflex femoral artery. Now here's an important clinical point regarding the tensor fascia lata muscle and the associated IT band. A lot of times you'll have patients that are going to complain of pain at the lateral knee, really at the distal attachment of the IT band over here. And if you put pressure on the distal IT band, it provokes a familiar pain. This is associated with IT band syndrome, and there are special tests used to evaluate this, like the Noble compression test, and we cover that in separate videos. And so the temptation would be to put targeted treatments toward the IT band because that's where the pain is. However, those targeted treatments of the IT band, like foam rolling or manual therapy or even dry needling of the IT band specifically, are actually ineffective for treating IT band syndrome. So instead of focusing those targeted treatments on the IT band itself, you should target them to the muscular part, that is the tensor fascia lata muscle. Why would that be? So suppose you have a runner, and that runner develops IT band syndrome. Well, if you look at the mechanics of running, there is no double limb support. That's the difference between walking and running. In walking, there's a phase of double limb support. In running, there's not. It's completely eliminated. So you're alternating between right single limb support, left single limb support, right, left, and so on and so forth. And when you're in single limb support, let's say on the right, there are certain muscles on the right side that have to activate to promote stabilization in the frontal plane. And those would include the gluteus medius, gluteus minimus, and also the tensor fascia lata muscle. Now, what would happen if the gluteus medius and minimus were weak or overused, let's say? Well, they're not going to be able to contribute as much to that stabilization. And so you're still going to have to stabilize. So that percent contribution to that stabilization is going to increase for the tensor fascia lata. But it's not meant to provide that degree of stabilization. It'll provide some, but when you have to rely more on the TFL, it gets overworked, it gets fatigued, it gets ischemic, and eventually it becomes tight and a pain generator. And so even though the pain is typically felt down here at the knee near the lateral epicondyle at the IT band, the actual source of the pain is most likely tightness in the tensor fascia lata muscle. And so a lot of times for IT band syndrome, we want to focus on stretches of the TFL. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.